Thank you for taking time out of your very busy and tiring days and to join us this morning. My name is Phil Sunyag from Hamilton Medical, and my phone number and email address is up there, and somewhere floating around here I have a bunch of business cards. I'd be happy to share those with you as well. So we're going to talk today about your new T1 transport vents, and before we get started on today's presentation, I'd just like to ask if you had a chance to look at any of the online stuff and if you had any questions or concerns about the material that was presented there. If you didn't understand all of it, that's okay, but if you can remember as we go along anything that seems unclear, or if you have any uncertainty at all about things that I say or things that are presented, please stop me, because if you have that question, my guess is probably everybody else in the room has that question too, and so it's better to get it answered. As far as I'm concerned, there's no questions that are out of bounds, so ask away, you're not going to hurt my feelings. And if you don't know the answer, then it's not a stupid question, right? A couple of the folks have said, sorry to ask a silly question, but it's really not a silly question if you don't know the answer. So it's only a silly question if you ask the same question 15 times, then it's a silly question. I'm sure that won't happen. So anyway, the T1 is basically an ICU caliber ventilator in a small box, and has a lot of capabilities. Some of that will initially maybe be a little daunting for you because you're going to see things and the ventilator is going to present information to you that you're not used to seeing. But the good news is that the protocol, the way that it's written, is going to basically provide you the use of an advanced mode, closed loop mode, and we'll talk more about that, called ASV, or Adaptive Support Ventilation, and that's going to do a lot of the work for you. It's going to kind of diagnose the type of patient that you're dealing with, whether they're obstructed or restricted. It's going to select the appropriate rate and tidal volume combinations. And so we're going to talk about a lot of stuff that you're not going to need to use on a day-to-day basis today, just so you understand what the ventilator is doing and are able to troubleshoot if things aren't going the way you want it to. So basically what you're going to end up doing, and we'll review this in some detail, and we'll do it on screen and we'll do it live with the ventilators, is you're going to put in the patient's gender and their height, approximate height, and that will calculate the ideal body weight for you, and then you'll dial in the minute volume that you want the patient to achieve, and if you don't know what that term means, we'll review that as well. And the PEEP and the FiO2 as you do today, and press start. So you don't have to worry about big volume or small volume, high rate, low rate, I time, IE ratio. You don't have to worry about any of that anymore. So basically what's going to happen, if you can look on this ventilator here, you have three primary controls now. You have a percent minute volume, you have a PEEP, and an FiO2. Well, two of those are pretty familiar to you because you're setting them today. And in reality, the percent minute volume is the same thing that you're setting on your ventilators today. It's the rate and the tidal volume, but it's combined into one control. Okay? And it's indexed to the patient's ideal body weight. So you'll find that it's really, once we get past it's like buying a new car, right? Where's the windshield wipers and how do I turn the defroster on? Once you get past all that, you'll find that it's really very easy to use. So, good morning. We just wanted to have a couple of basic reviews. Again, if we're going to be kind of building a building here, and for those of you that have done any kind of construction, if you get off at the beginning, by the time you get to the 12th floor, you got real issues. So. You're used to using, as I understand it, ventilators that are volume control ventilators. So you're setting a rate and a tidal volume. Are you setting a flow, inspiratory flow too, or no? Okay. And you know that as the patient's pulmonary mechanics, the patient's condition changes, the pressure will change, right? And so one of the two basic tenets of mechanical ventilation is that if the volume is constant, the pressure is going to be variable. If you use a pressure control ventilator, 20/5, 20/5, etc., then the ventilator delivers a constant pressure, but the volume can be variable as the patient's condition changes. So for that reason, in the last, since I've been in medicine since the late 70s, volume control has been the predominant mode of ventilation for most patients. Pressure was used in infants, but now we have the ability to measure very small flows and very small volumes very accurately and very quickly, and so now the technology has moved to the point where most neonates are also, even a 400 or 500 gram baby, are also ventilated using volume. And so that's accomplished through something called volume targeted pressure control, so you kind of get the best of both worlds. You get a constant volume and a square pressure waveform that's constantly being adjusted by the ventilator in pursuit of a target tidal volume. So it's more physiologic because nobody breathes the same tidal volume every time. And typically volume control ventilators used a fixed flow, so it was, you know, X amount of volume at X rate at X amount of flow rate. But nobody breathes like that. So if the patient halfway through the breath decided they wanted to go and gasp a little bit or take an extra breath or take the volume in more slowly, the ventilator precluded them or prohibited them from doing that. And so it was very aphysiologic and it wasn't very comfortable. Well, if the patient's uncomfortable and struggling and probably already sick and has this tube down their throat, they're going to start moving around, and then it's going to be the classic, the patient's fighting the ventilator, right? Well, that's never been true. It was always a lie. It's a lie today. It'll be a lie tomorrow. The truth is the ventilator wasn't set properly, and the patient is now desynchronous from the ventilator or asynchronous from the ventilator, and so the patient struggles, just like if any of us ran down the hall and somebody put their hand over our mouth and only let us breathe in at a certain flow rate, we wouldn't like it, and we'd be swatting at them. You know, I certainly would be. So the volume modes on the T1 are all volume-targeted pressure control modes, and those are the APV CMV, which we're not going to use generally. We're not going to talk about that too much today. APV SIMV, and ASV, which is adaptive support ventilation. So probably 90% of the time you're going to be using ASV, and the only people that you won't be using ASV on are ones that will fall into kind of a special category, those patients that are chronically air hungry for some reason, the diabetic ketoacidosis, or the neuro patient that's herniating their brain stem, or, you know, the patient that's extremely anxious or in pain that you can't sedate, or for whatever reason it's clinically unwise to do so. So that's kind of the 30,000 foot overview. Beyond that, what we want to do is talk about a little bit just, you know, what our goals are in ventilating the patient. Obviously, first and foremost, we don't want to make anything worse. That would be a bad thing. It's already a bad situation by the virtue of the fact that we're there and the patient's intubated. And since we know that positive pressure mechanical ventilation can be dangerous in and of itself, because 50% of the time it's aphysiologic, right? We don't breathe in normally under positive pressure, we breathe in under negative pressure. So if we use too much pressure and we don't get the settings right, it's possible to cause cardiovascular collapse and impede venous return and blow a lung, all those types of things. And then to the best of our ability, beyond being safe and protecting the patient from expiring, we want to make the patient as comfortable as possible. And ASV, I think you'll see, will help us to accomplish those things. So it can be used in a variety of patients, pretty much every type of patient except the ones we talked about. And that's really just a function also of the way you're using the ventilator, and we'll talk more about that. So like everything in medicine, ASV is an acronym. It stands for Adaptive Support Ventilation. I've been working for the last few months on my private pilot's license, and I thought medicine had more acronyms than any other thing, but I've come to find that aviation has an acronym for the word I, so medicine is second in that respect. The other thing that ASV will do is that it gets rid of some of these things related to which control do I have to adjust, which way do I turn the knob, when do I turn the knob, which patient should this knob be turned up on, which one should this be turned down on, and so forth. And in fairness, there are those among us that are good at mechanical ventilation, and there are those among us that aren't as good, and there are some of us that are, most of us are in the middle somewhere. And so it helps to kind of standardize practice variations. So if, you know, mechanical ventilation, and certainly we understand, as does your management, mechanical ventilation isn't your only responsibility. You got a lot of other stuff going on while you're taking care of the patient, the least of which may be having to protect yourself from being thrown against the side of the aircraft or to the side of the inside of the ambulance. And you've got IVs and all sorts of other things to worry about. So this will make it easier for you. It will make it safer for the patient. And I think the overall quality of care will be enhanced as well. So we know today that we have our patient. Thankfully, they're there to give us something to do during the day. And us, we're there trying to help them out and keep them from dying or getting sicker. And so we assess their physiologic needs, and then we make some plan of action, and we dial that plan of action as it relates to the ventilator into the controls, and then the ventilator performs that work on the patient. One disadvantage of that type of ventilation is that it's a static setting. We can set the patient in such a way that, you know, they're dressed to the nines, if you will, everything is perfect, and we go down the road or, you know, through the air 10 miles, and all of a sudden the patient's condition has changed. The tube slipped into the right main stem, or the patient slipped down on the gurney, and now the seatbelt is compressing their abdomen or their diaphragm in such a way that it's restricting their ability to breathe, or the ventilator to breathe for them. Good morning. So what closed loop modes of ventilation do is the first two parts are essentially the same, but the difference is the work, if you will, that the ventilator does on the patient and for the patient, and it's dynamic. So as the patient's condition changes, the ventilator, as the name implies, adaptive support ventilation, the ventilator will adapt the way that it interacts with the patient. And you have some circuits, they're not hooked up to your ventilators yet, but at the end of the circuit, the work end of the circuit, you see a little blue adapter, if you will, and it has two hoses connected to it. That's called the flow sensor, and we're going to calibrate that and do a tightness test a little bit later. But all the things that you see on this ventilator up here and the things that we're going to demonstrate and work with today are possible because of that flow sensor. So that flow sensor is measuring pressure, flow, and volume 200 times a second. Everything that goes in and out of the patient goes past that flow sensor, and the ventilator then takes that information, and because of the high sampling rate, is able to produce a lot of information for us. So ASV is defined as a closed loop mode of ventilation. Biofeedback would be another synonym for that. It's taking that information and it's regurgitating it back into the ventilator. The ventilator analyzes it and then does something for it. So some of these slides are, if you will, marketing type slides that are used in presentations, and I plagiarized and pulled from other presentations when I put this one together for you. But the important thing here is the highlighted stuff at the bottom, and that is that when we're using ASV, or adaptive support ventilation, all the breaths are volume targeted breaths, meaning that every time the ventilator gives the patient a breath, it's looking to achieve a target tidal volume. Unlike SIMV, which you may or may not have used in the past. So in SIMV, you have some mandatory breaths. The ventilator says, hey, I got to give you, doctor said I have to give you 6 breaths a minute. And then you can do what you want. You can kind of free form in between. Well, those free form in between breaths are either pressure supported or not. The patient either does their own work, or we dial in some kind of pressure support on top of the base level PEEP. But there's no volume guarantee, so the patient can take really big tidal volumes or usually very small volumes because they're sick and they're unable to breathe spontaneously to an efficient level on their own. And so in an IMV mode, the patient can breathe real fast and then they get a big breath, and it may be desynchronous, and then it pressure limits and the ventilator dumps and the patient doesn't get any volume. And so it's basically, not the best situation. So again, keep in the back of your mind, that's one of the keynotes. I think the key takeaways is every breath that the ventilator is going to deliver to the patient is going to be a volume targeted breath. And we'll talk about what that target is and how it's derived and when it changes and why it changes here in a few minutes. Okay, so we can use it in pediatric patients. We can use it in patients, the ventilators as they're configured in front of you can be used on patients down to 3 kilos. That's an actual body weight. The 200 kilogram patient, that would be an actual body weight as well. And the reason it limits out at about that weight is for using ASV, if patients, and this is only pertaining to ASV by the way, excuse me, is if patients become grossly afield of their ideal body weight, 3, 4, 5 times their body weight, then because of the way the ventilator is this feedback, this closed loop scenario, the ventilator will interpret that extra body mass as a change in compliance, which in fact it is. So very large breasted women or people that are morbidly obese, or they have severe abdominal compartment syndrome and their belly's full of water, things like that, or fluid of some type, the ventilator will adapt to that to a point. But when it gets so far afield that the patient's really divergent from their ideal body weight, then we can run into problems, and we'll talk about that as well. But we can use it on the patient that just got banged on the head, slipped on the ice and hit their head and went unconscious and had to be intubated to protect their airway, right up to the patient that's in the aggressive form of ARDS or whatever. So it's not really something that you use only for weaning patients or only for patients that aren't really sick or just coming out of anesthesia. We can use it on pretty much the full gamut of patient types. And as we go along, we have a lot to cover, and there's a big group, which means it's a little slower when we get into the hands-on stuff. So if I say something again, or you don't understand it, or you feel uncomfortable with it, let me know, and we'll circle back around on it. There will be no test on calculating the Otis equation, but that is basically the predicate that the technology is based on. So Dr. Otis, back in the late 40s, did a bunch of research, and he figured out that for any combination of pulmonary mechanics, compliance, resistance, dead space, etc., mammals will select a rate and a tidal volume that produces the least work of breathing. I equate that to kind of a movie buff on the weekends when I don't have to be blabbing my face at talking about ventilators, I kind of veg out and we'll watch, and I'm a big fan of Jurassic Park. And I can't remember, Jeff Goldblum, the guy with the glasses, right? He was kind of the practical scientist, if you will, that came along. And in the first edition, when the dinosaurs had run amok and were taking over the island, right, he says, well, you know, nature has a way of just finding its way through. You know, we can try to exert things on our environment, but nature, Mother Nature, has a way of finding her way through. And essentially what Dr. Otis concluded is that, based in part on an evolutionary process, certainly, and just work of breathing, that mammals will pick a rate and a tidal volume that yields the least work of breathing to support their metabolic demand. And sometimes physicians will debate that a little bit, or some clinicians will, and the best way to prove that to yourself in your spare time is go hang out in the pulmonary function lab of a busy hospital and watch the way that the COPD patients breathe, right? They go right? So they have a very different pattern than the people with pulmonary fibrosis, you know, and the rest of us are somewhere in between. Well, why is that? It's based on their pulmonary mechanics and their body's desire to produce the least work of breathing. So all that ASV does is takes the information from the patient, and it says, based on the minute volume that we, the clinician, have ordered, if you will, or dialed into the ventilator for the patient, a larger tidal volume and a smaller rate are the safest thing to do, or the patient's going into ARDS, and so we should use evidence-based medicine says that, you know, this ARDSNet ventilation protocol with lower tidal volumes and higher rates makes the most sense. Well, in order to implement that, A, you got to know what's going on with the patient, right? How to interpret the information from the ventilator. B, you have to know, after you've determined what it is, know which way should I go, left or right, with their ventilator management. Then you have to do that. So it's incumbent then upon us to do everything. So ASV, if you will, arguably is like having an autopilot with you. It's like taking a well-trained respiratory therapist or nurse or EMT or physician that's really good at mechanical ventilation along with you, and they're kind of riding shotgun and helping you out. That doesn't mean you have to use it. That doesn't mean that it's always right. That doesn't mean that it's always the mode to use on every patient, but it will be in probably 90% of the patients you ventilate, and we'll talk about what that other 10% looks like as we go along. So the byproduct of that nasty formula is essentially frequency, the F, or rate. So we put in the minute volume, and the application of the Otis equation produces the optimum rate. And if you divide the rate into the minute volume, the byproduct is tidal volume, right? So we know that when we put in a rate and a tidal volume, rate times tidal volume equals minute volume. That's as sophisticated as the math gets in this exercise and with using ASV. So we go from what's on the left here to what's on the right. So which one would you rather have to manage? Would you rather have to manage all of those controls on the left or those on the right? There's probably a small instance where there may make some sense in using the one on the left, but practically speaking, if you get to the same end result and you have devote less time to trying to figure out what to do with all of those controls, and we can percolate it down into 3 controls, doesn't that make more sense? And we're back to that whole thing about, you know, varying levels of acumen, and do I have time? My IV's infiltrating or the patient's doing something else. I don't have time to deal with the ventilator right now. So the ventilator is going to help us out and take care of a lot of that. Now we're going to start getting into the justifications of why, and basically this was a retrospective study that just showed that the tidal volume ranges up there on the top on the right, 5.6 to 10.4, varied based on the patient's disease process. So the patients with normal lungs had tidal volumes in the 8 mLs per kilo range. You probably heard 6 to 8 mLs per kilo bantered about before as a lung protective ventilation strategy. We'll talk some more about that as we go along. The obstructive lung patients had tidal volumes that were approaching 10 mLs per kilo. We'll talk more about why that is. Why does their tidal volume target need to be bigger than the normal patient? And then if you go to the other extreme, so you have obstructive at one end of the disease timeline, if you will, and you have restrictive patients, the ARDS, pneumonia, tube went in the right main stem, slipped down on the gurney and the seat belt's too tight across their abdomen. From a ventilator management standpoint, those things are basically the same manifestation. It doesn't really matter whether it's the patient or the patient's condition. just like with obstructive. It could be that the patient didn't all of a sudden develop asthma or COPD. It could be that they're simply biting the tube, or that they have lots of secretions and they need to be suctioned, or some maniac stuffed a juju bead or an M&M down their ET tube. You know, those things all have, basically when it comes to managing a patient on a ventilator, it all ends up being essentially the remedy is pretty much the same. Okay, so as I mentioned before, and now we're going to get into some hands-on stuff here. Basically what we're going to do is put in the gender and the height, and then we'll get through the rest of this stuff. So if you go ahead, and I'll show you on my demo ventilator up here. So this button up on the top, so your ventilators are going to look like this. So press this button, this on-off button, one time, and we'll see if everybody did it at the same time, because we're going to hear a bunch of beeps come on. And then you're going to have a yellow alarm that's going to come up, which is just the ventilator saying, hey, by the way, I'm running on battery. So once it comes on and you hear the little alarm and the yellow light comes on, press the alarm silence button twice, and that'll cancel out the alarm and it'll get rid of that alert. Okay, excellent. So the first time you press it, it cancels out the alarm and turns the alarm off. And pressing it the second time, just press it one more time if you would. Oh, are you up and running there?
Yeah.
Okay, we got one light still on. There you go. Okay, did yours go out as well? Mm-hmm. Okay, excellent. Okay, so we see some different things on the ventilator here. These are the three primary modes that you're going to be using, ASV, and your ventilator, as did mine, came up automatically into ASV because that's the mode that we're going to use 90% of the time, if you will. Plan B is going to be this middle one, which is called PSIMV+. We'll talk more about that. And then when you're doing non-invasive, it's going to be NIVST. So those modes are the same as the modes that are available up here under the modes key. So if you press the modes key, you'll see that ASV is illuminated, which means that's the active mode. And in that second grouping here, PSIMV, that's that same mode. These top two are the volume targeted pressure control without the adaptive stuff that's included in ASV. So that's just straight volume targeted pressure control. The next grouping are all the pressure control modes. So that would be the assist control, the SIMV version, and the spontaneous. So that would be, you wanted to put the patient on BiPAP, but they were already intubated, but you didn't really want to apply any of the other stuff of positive pressure ventilation. And then the bottom two are the non-invasive modes. And we'll talk more about those as we go along as well. Below that, you'll see male and female. So sometimes you got to peek under the sheet, right? But most of the time you can figure out what the patient's gender is. One of your colleagues yesterday asked a question the first time ever. I always like those first time questions. What if the patient has had a Bruce Jenner scenario and had a gender transition? Should I put in male or female? And I said, well, at the end of the day, it's not going to make too much difference, and you may not be able to ask that question because the patient's incapacitated. But biologically, it's still Bruce Jenner, or whatever Bruce Jenner's name is now, is still biologically a man from a DNA standpoint. And the reason that we're putting in the gender is that if a woman and I were the same height, my airway would be larger than hers. She would have higher airway resistance, probably because my airway is larger than hers. And so I'm not a statistician, and I didn't come up with all the tables which are based on stuff out of the medical school at the University of Pennsylvania in Philadelphia in 1970, whatever it was. It's in the book. If you're interested in that, feel free to look it up. Let me know what you find out. But if we select, let's pick a female patient. So if you go ahead and, the short form instruction for using the ventilator is touch what you want to change. Okay, so that's the second takeaway. When in doubt, touch something, and if it's something that's going to be fairly significant, you're going to have to touch it twice to confirm that that's what I want to do, and or it's going to turn orange. Okay, so let's put in a female patient that's 5'5". So if I selected female, and now by touching the height, which should be in inches, because we've configured it that way for you, let's turn that down until we get a patient that's 5'5", which would be 65 inches. And then to select that, so when you touched it, it turned orange, right? And then you turn the press and turn knob to make the adjustment. Then you have to do one of two things. You either touch it and turn it orange, make your selection, and then either touch the that same control variable again, or, because I'm fundamentally lazy, my hand is already on the press and turn knob, so if I just press the press and turn knob, then that selects it as well. If you make it something's orange and you make a change and you walk away or get diverted, your attention is diverted for some reason, it will just revert back to the previous setting. So if you wanted to change the patient's FiO2 from, well, let's do that because our vents, yours probably came up at 50%. So I programmed them so that it would, that's right in the middle, so you don't have as far to turn it. So when we get to using the vent, if we don't turn that to room air, we're going to get alarms because we're not hooked up to anything. So let's all turn our FiO2 down to room air. So activate the control, and then just turn the press and turn knob until we get to room air, and then either press the press and turn knob, or, so you're now all certified to make changes on the ventilator. That's as complicated as it gets. The point again is if you had turned it from the patient was sick and you went from 40 to 80%, and as soon as you turned it, you got some notification over your headset or something else happened and you got called away, then after an amount of time, I think it's 30 seconds, the ventilator would revert back to the previous setting, so you haven't made a change. I was surprised my wife bought a new car, a Ford Edge, and there's no button when the door locks, there's just a little light there, and so when you lock the door, actually it locks when you pull away, right? After you go 5 miles an hour or something, the doors all lock automatically. And then when you go to get out, when you pull the handle, nothing happens, because pulling the handle the first time is the car saying, oh, you want to get out? And then you have to pull it a second time, yes, I really want to get out, So I think the first time you pull it, it unlocks it, and the second time it opens the door. But the first time I was like, let me out. So, okay, so now we're going to do a couple of things that we would do before we use the ventilator, and that would probably be even before we did what we just did. So your ventilators don't have circuits on them yet, and let's not put those on just yet if you would. And one of the things that needs attention is called the expiratory valve. So if you go ahead and turn it so you can see the expiratory valve, turn it so that the screen is facing whatever direction that is, to the left. And it comes out, and there's also a membrane on it, and you can take that off as well. Now, these come in two varieties. This is the reprocessable multi-use version that would need to be Sidexed periodically, etc. Or there's a single patient use version, and I'm not sure what your management group has decided to do yet. That we seem to be going back and forth about how they want to do that. But in either case, they work the same. The only difference is this is blue, I believe, and this is clear in the single patient use version. Okay?
Would that be automatically connected to the circuit?
If they purchase it that way, it would all come connected in the bag with the flow sensor. Yes, sir. Mm-hmm. So you notice there's a little notch on the diaphragm, and there's a little notch on the top of the housing as well. So the easiest way, if you have to take it off or check it, is just put the notch over the little tab, and the rest of it just fits on there like a little cap. Okay? We're going to do a tightness test here in a minute, and we're going to do a flow sensor calibration. And in any case, about 95% of the time, if you have a problem with either of those things, it's related to the fact that that's either got a hole in it or it's not on properly. So somebody put it on and the little tab is caught on the cup or whatever the case might be. And then to put it in, it connects with kind of a lure lock type of a mechanism. So if you put it in the ventilator and you turn it to the left, it'll allow it to go recess all the way in, and then just turn it to the right, and you'll feel kind of a click. There should be no uncertainty about whether it's in or not. If it's not in, it won't, and you pull on it, it'll come out. If it's locked in, it's in place. Okay?
Now, multi-patient use, you said it needed to be Sidexed.
Yes, or it could be gassed, or it could be put in a Pastromatic. There's also kind of an intermediate solution, and that would be you could use an HME or a filter. There's some of that blue, some of you have an HME. Could you hold that up for us? So an HME is a heat and moisture exchanger, and it basically takes the exhaled gas from the patient and it captures the humidity in their breath, and then it captures it in the wick, and then it gives it back to them. So the patient is not breathing dry gas. It's my understanding you're not doing that today. You're using some sort of a filter on the ventilator. But part of the problem, thank you. Part of the problem with doing that is that the way that the circuits attach, unless you're making your own circuit, this is actually just a dual limb circuit. The respiratory therapy team is going to make their own circuits out of Tygon tubing and just put a Y on it and the flow sensor, which you can purchase separately. Then it wouldn't be so difficult because you could use one of these. Somebody described it as a flying saucer type of a filter. I think you use those now. But on the circuits that you have there, you'll notice that if I put that on one of those manifolds, you'd have to have two of them, otherwise the other one's not going to connect to the ventilator. So you'd have to have some sort of an adapter or whatever. And filtering the gas going from the ventilator to the patient or going back into the ventilator really isn't necessary, because the ventilator is drawing in the room air through the back of the ventilator through that little white dust filter on the back, and then there's actually a HEPA filter inside the ventilator that's changed semi-annually. And so the gas is filtered already going to the patient. And of course, unless you had some nastiness in the tank, but that's going to go through some internal filters as well. And then the expiratory gas and any fluid or whatever that gets into the circuit doesn't go into the ventilator anyway, because it stays on the outside of that white membrane. So,
How often does that white membrane need to be replaced?
when it doesn't work.
Okay.
Yeah. So on the counter behind you there, I don't know if I can get back there, there's a little box, looks like a little white container that looks like a pill box. Yeah, that one. If you open that, so every ventilator came with a box of those, and there's 5 of them in there. So I've had membranes on the expiratory housing for my demo units, and when we ship the ventilators back and forth, if we need to, we usually take all the consumables off, and I've used expiratory housings and membranes for years without them being damaged. Eventually what happens is it gets a pinhole in it because somebody dropped it on the floor and ground on it with their foot, or it gets torn. If they're being sent to central supply, those sometimes the central supply folks, God bless them, are a little bit like the FedEx guy. If it says fragile, they're going to try to beat the hell out of it, you know, kind of thing. Oh, my sensor, is there a red light going on back there? Sorry. You can bleep out all the bad words, right? Okay. But yeah, so if you ever had a problem and you were using that reprocessable and don't throw away the whole thing, just put a new membrane on there. So it may not be a bad idea to have 3 or 4, a package of those in every squad or on every helicopter or whatever. If you have, I think you have a bag that you're going to put these in or what have you. But it's a great question. Thank you. Okay, so go ahead and put your circuit on, and the circuits, you can open yours up if you didn't have one there. I can get you an extra one here. Oops, sorry. Throw that on top again. That's not very nice. It's just like practice for Christmas. That's right. All right, so you can actually put those are actually coaxial circuits, so that the blue tube is the inspiratory limb, and the space between the blue tube and the big tube and the corrugated white tube is the expiratory limb. So it's really a dual limb circuit. It's just a tube within a tube, if you will. I apologize, I didn't have any short ones, so some of those are for MRI machines, and they're about 9 feet long. So just throw the rest on the floor or whatever. Okay, so when you put that little manifold, as you've all done except these guys, and they hit a late start because their circuits weren't ready to go.
So these are MRI safe. So take this out.
These ventilators are not. There's one that looks just like this that is, but it's about twice as expensive. Okay, no, you're fine. So let's just put that in. So put it, let you do it. Put it in there, turn it to the left, now turn to the right, and it's locked in. Now you want to grab the other end of the circuit. Okay, and then this would fit on here like this. Okay, and then pull these. So when you first take these out of the bag, the flow sensor, it's going to be like string cheese. Just pull the 2 pieces apart. If you pull them in the opposite direction, it's cold, so it doesn't want to tear. There you go. And put the blue tube